Today I'll be dealing with the 5th edition, that is this article in Leukemia published in June 2022. That is 5th edition of WHO classification of hematolymphoid tumors, WHO HEAM5. They have abbreviated it like that. And the book is probably coming towards the end of this year or maybe early next year, but this review article has been published, and this seminar is mostly based on that only. And I have tried to include whatever was relevant from the 4th edition also, so that the comparison is relevant for the people who have not read the article yet or who are still going through 4th edition. So that's why I have just put a line here that updates and comparison with the previous edition. So with that, I will start. So like all other, this 5th edition of classification of WHO classification of tumors, this hematolymphoid tumors classification also applies a hierarchical system for classification. So what do we understand by hierarchical system? That it organizes diseases in order of increasing level of specifications. Okay, so first you give a broad category and then you further go deeper into that. Okay, so how they have applied this hierarchical system? First, they have put a broad categories like immature or precursor B-cell or mature B-cell. So I'll be talking about B-cell neoplasms. Okay, so first they will classify them. They have classified them as categories, broad, and then the categories are further subdivided into family or class, like large B-cell lymphoma or follicular lymphoma or splenic or lymphoma or marginal zone lymphomas. Similarly, the family and classes described below the categories. Among the categories and these families or class, they are further subdivided into entity or subtypes. Like among large B-cell lymphoma, there are 18 subtypes. Types, and one of them is like DLBCL NOS. So they have been further subdivided into these entity and types. They are further subdivided into types or subtypes, like DLBCL NOS with germinal center B-cell like. So the subtypes are not there in all the entities, but wherever it is relevant, the entities are further subdivided into the subtypes. And this WHO also follows the same hierarchical system in the diagnostic criteria also. The concept behind this is because they have been trying that the criteria that they have been putting through, they can be as universally applicable globally as much possible. And since not all the places have all the resources which are required, that's why these diagnostic criteria also they have divided into two. The first is essential criteria. Essential criteria are the minimal criteria to allow the diagnosis of an entity. Focus on the term entity as universally as possible. So in the like large B-cell lymphoma family, the DLBCL NOS, that is the minimum criteria will allow you to diagnose DLBCL NOS among the large B-cell lymphoma. Okay, so that is for the resource constraint. So okay, they are assuming that this much resources will be available everywhere, so people will be able to diagnose, at least put them in the distinct entities. They may not be able to subtype them, but at least they can put them into the entities. But again here, although they have tried as much as possible to include this, that advanced techniques are not required, but then there are certain categories like high-grade B-cell lymphoma, that MYC BCL2 rearrangement, that you cannot actually diagnose without this molecular and genetic. In that case, they have given the what you can do about this. They have given some recommendation about that also. So the other category is for the desirable criteria. Okay, so desirable criteria are the criteria which they are not required for the diagnosis, but once the condition is diagnosed, they aid in confirmation as well as the refinement of diagnosis. And usually they require advanced techniques. That's why they call them desirable, because many times you need to diagnose, require a mutation or something for the targeted therapy and all. So all these cases, they are actually desirable, but they are not essential for the diagnosis. So they are included as desirable criteria. And as I was talking about special circumstances, like the conditions where the resources are unavailable for the diagnosis, or the quality or quantity of the material that have been provided is suboptimal. In that case, label based on the family name of the entity can be applied. Okay. So you can just call it as LBCL if you cannot further subclassify it. Okay, the family. That's why I have highlighted the word family, that you can classify it as such. And then there have been a few novel subtypes that have been proposed for some entities. Like for the Burkitt's lymphoma, they have included as EBV positive and EBV negative status. They have recommended that you classify them like that, but they have not included any new provisional entities. Why? Because by definition, these provisional entities, they lack sufficient evidence, and that's why they have been not included. No provisional entities are there in the new classification. Okay, then among the categories, the immatures have been classified before the mature, like the precursor B-cell these lymphoblastic lymphomas, they have been described before the mature ones. And among the particular category and the family, the indolent ones have been described before the aggressive one. Within a family, they have gone by from indolent to the aggressive. The classification is like that. Okay. Then they have, for the first time, included these non-neoplastic mimics or differential diagnosis of lymphoma. Why they have done this? Just to prevent the overdiagnosis of a lymphoma, and as well as to improve the recognition. Okay, that's why these are included in the classification. The germline tumor predisposition syndrome. It's the genetic predisposition is known for many lymphoid proliferations, like the genetic conditions like ataxia telangiectasia, Nijmegen breakage syndrome. So in these cases, how do you categorize the diseases? You diagnose them by the conventional criteria, like you went by that Burkitt's lymphoma or anything. And then you put at the end of the diagnosis, it's AT related, that is ataxia telangiectasia related, or NBS related. Why it is important to put them like this? Because see, these genetics, the treatment protocols are different when the person is affected from these conditions. Like this AT and this NBS, both are chromosomal breakage syndromes. Okay, so in these cases, if you go by the conventional chemotherapy, that will just make them prone for many other future malignancies. Okay, so that's why the treatment protocols are different from them. So that's why it is important that they categorize them. So this new classification includes chapters on genetic predisposition syndromes separately. And then with increasing understanding, it has been recognized that many lymphoid proliferations, they are associated with this inborn errors of immunity as well as acquired immune disorders. So separate chapters for them also have been included in the classification. So the first entity, that is tumor-like lesions with B-cell predominance. It is a new addition to the WHO. 5th edition. It has not been included in the 4th edition. So it's an entirely new category. And it includes 5 entities. First is reactive B-cell rich lymphoid proliferations that can mimic lymphoma. Just notice these are not lymphomas, these are mimics only. Okay. So first is reactive B-cell rich lymphoid proliferation that mimic lymphoma, like progressive transformation of germinal centers, infectious mononucleosis, this florid reactive hyperplasia, lymphoma like lesions of female genital tract, and SLE, and a lot more than that. And then second is IgG4 related diseases. Third is unicentric Castleman. The Castleman disease, the 3 entities have been included as 3 separate entities. So fourth is idiopathic multicentric Castleman disease. And these first 4, these are the new addition to the WHO classification, this 5th edition. While this 5th entity, that is Kaposi sarcoma, that herpes virus is HHV8 associated multicentric Castleman disease, it has been included in the 4th edition also. So like I said, the first 4 entities, they are new to the 5th edition, not included in the 4th edition. While this 5th entity, it has been classified as multicentric Castleman disease in WHO HEAM 4th edition, revised edition. Okay. Okay, so now coming to the major part of our today's talk, that is mature B-cell neoplasms. So the first entity among the these mature B cell neoplasm. Mature B cell neoplasm is the family, okay? And this, in this family, first entity or type is the preneoplastic and neoplastic small lymphocytic proliferations, okay? So the key points in this are the monoclonal B-cell lymphocytosis and CLL, SLL, they remain, while this B pro-lymphocytic leukemia is no longer an entity in the new classification. So that's how this is. Now it has only two entities, that is MBL, monoclonal B-cell lymphocytosis, and the second is chronic lymphocytic leukemia or small lymphocytic lymphoma. Okay. So what are the changes that have been done from the 4th revised edition in the 5th edition? So there have been 3 subtypes of MBL recognized. Previously also there were 3 subtypes of this MBL, but now I'll just come to the change. But the third entity is a little bit changed. Okay, so why it is important to recognize this monoclonal B-cell lymphocytosis? Because clinically it is relevant. It is characterized by immune impairment with suboptimal response to vaccination and increased risk of infection. So monoclonal B-cell lymphocytosis, by definition, it has a clonal B-cell count. Focus on the word, not the lymphocytosis less than 5,000. Clonal B-cell count that is less than 5,000 per microliter. It can be either of the clonal population, it can be either have a CLL, SLL phenotype, okay, that is CD5 positive, CD10 negative, or it can be a clonal non-CLL, SLL phenotype, okay. So the clonal CLL, SLL phenotype, it is further subdivided based upon the count. Okay, less than 5,000 is monoclonal B lymphocytosis, but then it has been further subdivided into 2. One is when there is a B cell count which is less than 0.5 or 500 per microliter, or then it is called low count MBL. And the second category is when B cell count is more than 500, but it is less than 5,000, and the clonal phenotype is that of CLL, SLL, then it will be called CLL, SLL type MBL. So what was the need of classifying these 2 entities separately? Because they behave differently on the clinical context. See, this low count MBL rarely progresses to the CLL, while this high count, or previously it has been called as high count CLL, SLL. Now they have just given it as CLL, SLL type MBL only. So this, in most cases, it progresses to the CLL. So that's why they have separated them as 2. While this clonal non-CLL, SLL phenotype, it is called as non-CLL, SLL type MBL, and in most of the cases, it is marginal zone or of marginal zone origin. Okay, so in the previous classification, the first 2 were high count CLL MBL, and the second was CLL, SLL, low count and high count, and the third category was atypical CLL type MBL. But now this article does not talk about atypical CLL type MBL. The atypical CLL type MBL was CD5 positive, 23 was negative, and 20 was bright. While in case of a typical CLL, the 20 is dim and 23 is positive. So that's why it has been classified as atypical CLL. So we will need to wait for the book for the clarity on this point, that what happened to this atypical CLL type MBL. Okay. So the immunophenotyping for CLL diagnosis, in this also, they have described the essential and additional markers. Okay. So the essential marker includes CD5, CD19, CD20, CD23, and surface or cytoplasmic kappa or lambda chains. Okay. While the additional markers, they include CD10, CD43, CD79B, CD81, CD200, and ROR1. All these markers, why they are called as additional markers? Because see, they are not required for the diagnosis. Additional markers, they are useful for the differential diagnosis from other small B-cell leukemia lymphomas. Okay. So the genetics of the CLL also has been properly described. Again, it has been further subdivided into essential and desirable. Essential are those genetic features which are required for the prognostication, full prognostication of the CLL, and that includes cytogenetic markers like deletion 11q, 13q, 17p, and trisomy 12. while the mutation among the TP53 mutation and IGHV somatic hypermutation, and the B-cell receptor stereotype subset analysis, particularly subset 2, which has been associated with an adverse prognosis. And these are TP53 and IGHV somatic hypermutation. They have been included in the CLL International Prognostic Index, that along with age, clinical stage, beta-2 microglobulin status, etc. Okay. While the desirable criteria or genetic features, they are not required for the prognostication, they are required for the targeted therapy, and it includes detection of karyotypic complexity in BTK, PLCG2, and BCL2 mutation status. In the setting of transformation, this article says that Richter transformation should be used. The term Richter transformation is recommended over the Richter syndrome. While this B-cell pro-lymphocytic leukemia, this entity is deleted, and it is included now in splenic B-cell lymphoma leukemia with prominent nucleoli. That is a new addition to the WHO 5th edition. And this B-cell pro-lymphocytic leukemia, the cases which are CD5 negative, they have been classified as splenic B-cell lymphoma leukemia with prominent nucleoli. Coming to the next entity, that is splenic B-cell lymphoma and leukemias. The key points is there is a new entity that is called splenic B-cell lymphoma leukemia with prominent nucleoli. It replaces the cases of which have been previously classified as hairy cell leukemia variant and B-cell pro-lymphocytic leukemia. So just remember, the hairy cell leukemia variant and BPLL now don't exist in the WHO classification. They have been included in the splenic B-cell leukemia lymphoma with prominent nucleoli. So this category, this entity includes hairy cell leukemia. Second is splenic marginal zone lymphoma, splenic diffuse red pulp small B-cell lymphoma. All these three entities have previously been in the 4th edition also. The new addition is splenic B-cell lymphoma leukemia with prominent nucleoli. And as I said, it encompasses hairy cell leukemia variant and B-cell pro-lymphocytic leukemia. So what are the changes in this category or this entity? First is the splenic B-cell lymphoma with prominent nucleoli and this splenic diffuse red pulp lymphoma. In the 4th edition, they have been classified in a same group, and that was splenic B-cell lymphoma leukemia unclassifiable. But now they have been separately classified and recognized as separate entities. Okay, now they are not the subtypes of this leukemia lymphoma unclassifiable. They are separate entities by themselves. Okay, and this splenic B-cell lymphoma with prominent nucleoli is the new entity. I have been stressing on it repeatedly, and it includes hairy cell leukemia variant and all cases of CD5 negative B pro-lymphocytic leukemia. Focus on the CD5 negative B cell pro-lymphocytic leukemia because the CD5 positive ones will go into the CLL. Okay. It includes 0.4% of the all chronic lymphoid malignancy, and it affects predominantly the elderly patients and characterized by prominent nucleoli, and they are typical for the negative for the typical hairy cell marker, that is CD25, annexin A1, TRAP, and CD123. And clinically, they are more aggressive than the hairy cell leukemia, and that was the reason for the separate classification for them. So this splenic diffuse red pulp small B-cell lymphoma, which was previously a subtype of the lymphoma unclassifiable, it has been the morphological immunogenous features to differentiate it from the other three entities of this group, that is splenic marginal zone lymphoma, splenic B-cell lymphoma with prominent nucleoli, and hairy cell leukemia. These are described. So these entities, they are best discriminated by the pathological examination of the spleen, but many times the splenectomy specimen is not available. So in the absence of that, bone marrow can be used, but in the absence of splenectomy, the distinction is often not possible, but we can try on bone marrow to differentiate between these entities. So on the bone marrow examination, what we will see in case of this splenic diffuse red pulp lymphoma is, it will show a predominant intrasinusoidal pattern while the remaining, the splenic marginal zone and the prominent nucleoli entity, they will show diverse growth pattern. And like in hairy cell leukemia, as described, it shows typical diffuse pattern with reticulin fibrosis. The flow cytometry, it is one criteria has been given to differentiate it from the other entities, that is the mean fluorescent intensity of CD200 and CD180. If the ratio of these two is less than 0.5, it strongly favors a diagnosis of this splenic diffuse red pulp lymphoma over the splenic marginal zone and splenic B-cell lymphoma with prominent nucleoli and hairy cell leukemia. So this photo, I have taken this from the original article, and this pretty much sums up whatever we have read till now. Hairy cell leukemia in the 4th edition, it remains hairy cell leukemia only, okay? The splenic marginal zone lymphoma, the majority of cases will remain splenic marginal zone lymphoma, but a small part of it will go into this new entity, that is splenic B-cell lymphoma leukemia with prominent nucleoli. The third category is that I said, these two included in the splenic B-cell lymphoma leukemia unclassifiable, that's diffuse red pulp and hairy cell leukemia variant. So this diffuse red pulp is now a separate entity, so it will be classified as that, while this hairy cell leukemia variant, it will go into the splenic B-cell lymphoma leukemia with prominent nucleoli. This B prolymphocytic leukemia, the cases, there were 3 kind of cases. One which had CD5 positivity and the CLL immunophenotype, they are now called as prolymphocytic progression of CLL. The cases which showed this CCND1 expression and that 1114 translocation, they are called as mantle cell lymphoma, and the remaining, the CD5 negative B prolymphocytic leukemias which don't have this 1114 translocation, they are now classified as splenic B-cell lymphoma leukemia with prominent nucleoli. Okay, and the CLL, which has more than 15% of pro-lymphocytes, they will be called pro-lymphocytic. Previously also they were called CLL, PLL, but now they will just called as pro-lymphocytic progression of CLL. Okay, so coming to the lymphoplasmacytic lymphoma, key point is IgM matters. What are the category of this LPL remains, but there are 2 subtypes have been recognized in this new classification based upon the IgM expression status. And mid-88 L265P mutation analysis is required for molecular subtypes of IgM LPL. Okay, the IgM LPL is further subtyped based upon the mid-88 status. In CXCR4 mutation, it has been found in around 40% cases of this LPL, and it is again desirable for therapeutic purposes. It's not required. It is desirable for therapeutic purposes because it identifies the entities which are sensitive for this, like responsive for this BTK inhibitors, and that reduces the treatment time. So that's why it is desirable for therapeutic purposes. So the LPL, lymphoplasmacytic lymphoma, based upon the IgM status, it is of 2 types. First is IgM LPL or Waldenstromberg microglobulinemia. When the bone marrow is involved, that time this IgM LPL is called WM type. So this WM type constitutes 95% of the cases. The second would be non-WM type LPL. Mind you, it is non-WM, not non-IgM. Okay, it can be of IgM type, but it will not have that WM type. Okay, so this IgM LPL, that is WM type, based upon the mid-88 mutation status, this mid-88 is required for there are many marginal zone lymphomas and like multiple myeloma which shows prominent plasmacytic differentiation. It is useful in differentiating this LPL from these 2 entities. Okay, so based upon this mutation status, if it is positive, then it will be called mid-88 mutated LPL. That is accounts for the 90% cases of the LPL. And while if it is negative, then it will be called mid-88 non-mutated. Okay, while this non-WM type is further subdivided into 3. One is IgA, IgG LPL, or if there is no immunoglobulin, then it would be non-secretory LPL. And the third one is, like I said, IgM LPL without bone marrow involvement. To call it Waldenström microglobulinemia, and you need the bone marrow involvement. So if it is not there, then it will be called as non-WM type LPL. And these 3 are the entities. So coming to the marginal zone lymphomas, categories are not much changed, the entities are not much changed, but the cytogenetic and mutational profile differs by the anatomical site. And the mutation, cutaneous and marginal zone lymphoma, which have previously been described as extranodal, it achieves independence. Okay. So the common things among all marginal zone lymphomas is CD5 and 10 is negative, and they are commonly associated with plasmacytic differentiation. So the entities in the WHO fourth edition, there were two entities only, that is extranodal and nodal marginal zone lymphoma. Now this extranodal is further subdivided into two. One is the extranodal and the other one is primary cutaneous marginal zone lymphoma. While this nodal is further subdivided into nodal and pediatric nodal marginal zone lymphoma. Okay. So this, like I said, this primary cutaneous marginal zone lymphoma, it was not a subtype of this extranodal marginal zone. It was just described under this heading, but now it is a new entity. While this pediatric nodal marginal zone lymphoma, it was previously a subtype of nodal marginal zone lymphoma, but now it is a separate entity. So what are the new entities? What are the features of these? So primary cutaneous, it is entirely new entities. Previously, like I said, described under extranodal marginal zone lymphoma. It is separated because of a distinct clinicopathological features. While this pediatric nodal marginal zone lymphoma, it has been upgraded from a subtype of nodal marginal to a separate entity, and it shows overlapping features. Why it was separated? Because it shows overlapping features with pediatric follicular lymphoma. Although there is still not enough evidence for this, that's why they have not been grouped together, but still it has been separated from the nodal marginal. Maybe in the future classification, it will be grouped with the pediatric type follicular lymphoma. Now coming to the follicular lymphoma, the key point is the grading system is gone, the biological grouping is in. So in the fourth edition, there were four entities in the follicular lymphoma, that is follicular lymphoma, in situ follicular neoplasia, pediatric type follicular lymphoma, and duodenal type follicular lymphoma. In the fifth category, now this follicular lymphoma is further subdivided into three. One is classical follicular lymphoma, that is CFL, follicular large B-cell lymphoma, that is FLBL, and follicular lymphoma with uncommon features, that is UFL. In situ follicular neoplasia, thus the name is changed. Neoplasia is termed as neoplasm, the rest is same, while the pediatric and duodenal type follicular lymphoma remain the same. So the major changes are in the follicular lymphoma entity, that is divided into three entities now. So the first is the classical follicular lymphoma, that constitutes the 85% of all follicular lymphoma. It shows in part follicular growth pattern. It is composed of centrocytes and centroblasts and harbor the classical translocation 14-18, resulting in IgH BCL2 fusion. And then the follicular large B-cell lymphoma, it largely equals the follicular lymphoma grade 3B. Okay. So grading, now the new thing is grading of follicular lymphoma, it is not mandatory now. Why they have just removed that mandatory clause from this grading is because of the poor reproducibility, and then the different sizes of the 40x microscopic field, because it was based upon the how many centroblasts you are finding per high power field. So, and because different microscopes have a different size of this 40x microscopic fields, that's why. And the third is the clinical outcomes in the grade 1, 2, and 3A, they are not significantly different. That's why it was just decided that this grading is no longer mandatory. Just that the 3B grade, it will be called as follicular large B-cell lymphoma now. So the third subtype of this follicular lymphoma is follicular lymphoma with uncommon features, that is UFL. It is further subdivided into two based upon the morphology. First is blastoid or large centrocyte cytological features, and the second is with predominant diffuse growth pattern. Okay, so this blastoid one has frequently shows variant immunophenotypic and genetic characteristics. Okay, the genetic and immunophenotypic characters, they don't resemble with the classical follicular lymphoma. This is very frequent in this category. It is associated with inferior survival, and it needs to be distinguished from large B-cell lymphoma with IRF4 rearrangement. While this predominant diffuse growth pattern, it frequently occurs as a large inguinal tumor and associated with CD23 expression and absence of IgH BCL2 fusion. Okay, And there are frequent STAT6 mutation and 1p36 deletions. These things just to remember them, but they are like separate from the classical type and with uncommon features. Like the name itself says uncommon features. So it's the plastoid one has variant immunophenetic features, and this is showing the CD23 expression and IGH-BCL2 fusion absence. Coming to the next entity, that is mantle cell lymphoma. This entities, these subtypes, they mostly remain the same, but it's just the risk stratification is improved now. So the types in the fourth revised edition were in situ mantle cell neoplasia, mantle cell lymphoma, and leukemic non-nodal mantle cell lymphoma. Okay, so it's just that in situ, like I said, neoplasia becomes neoplasm, while the rest of the two remain the same. So like I said, the entities are not changed in the mantle cell lymphoma much, barring this name, but the risk stratification is improved. And also previously they all three were included in a single chapter. Now they have 3 individual chapters for the different types. Okay. So the genetics of this mantle cell lymphoma, the genetic hallmark of mantle cell lymphoma is IGH CCND1 fusion resulting from the translocation 1114. That is a well-known fact. It's not the update. Okay, 95% of the cases show this fusion on fish. Okay, what is important is this cyclin D expression. What are the new things that they have found in this? Okay, like I said, risk stratification is improved. So based upon the cyclin D1 expression, it can be either strong or it can be negative. So when it is strong, cyclin D1 expression is strong, then it can be two things. Either you will find a CCND1 rearrangement on the fish, and the CCND1 rearrangement, mostly it includes the IGH gene. Okay, but sometimes in some cases, when the IGH is not involved, that immunoglobulin kappa or lambda, the light chains may also be involved. Okay. And the second is when you are finding cyclin D1 expression, which is strong, but on fish, you are finding no CCND1 rearrangement. So what it could be, this has been described in the new classification. That is, they have found on the genomic studies that there are cryptic rearrangements of the IgK, kappa or lambda enhancer to the CCND1. So cryptic rearrangement is something that, okay, it is rearranged, but the rearrangement part is so small that it is beyond the resolution of the fish, like that is for around 50,000 kb, something that they can see. So sorry, base pairs. So if it is shorter than that, then you will not be able to detect it on the fish. So that can be found on the genomic studies. So this they have found, this is a new thing that they have added in the new classification. So see, just remember this, that in case of this translocation involving IGH, the other gene goes to the IGH. While in cases of the translocations involving kappa and lambda, the IgH kappa or lambda, the enhancer, they go to this the other gene. Okay, so there are sometimes cryptic rearrangements that is beyond the limit of detection by the resolution of fish. If some rearrangement, if it is smaller than that, then fish will not be able to detect it. In that case, you will find strong expression of cyclin D1, but there will be no CCND1 rearrangement. So genomic studies are recommended for this. And in these cases, often the cryptic rearrangements involving this Ig kappa lambda enhancer to CCND1 we have been found. The other thing is when the cyclin D1 expression is negative. In these cases, previously, it has in the previous edition, they have described this CCND2 gene and CCND3 involved in this translocation instead of CCND1. The new gene that there has been described is CCNE rearrangement. CCNE rearrangement is also involved in this. Okay. So just to quickly sum it up, this B-cell neoplasms, they have been in WHO HEAM5, they have been categorized in the hierarchical system. They're classified according to that. So first is the broad category, that is like mature and immature. Then these categories, they have been further subdivided into families or class, that is like mature B-cell lymphomas, further subdivided into that. Like large B-cell lymphoma. And then among these families, they have been further subdivided into entities or types, and the types in some cases, they have been subtyped. So, okay. And same way, the diagnostic criteria have also been redefined in same hierarchical manner, that is described as essential as well as desirable. Essential are those ones which includes the minimal diagnostic criteria required for the diagnosis of that entity. And desirable are the ones which aid in confirmation and refinement of the diagnosis, and they usually require the use of advanced technology. So that's why which is not available everywhere. So that's why they have been separated the diagnostic criteria into essential as well as this desirable. Okay, so then among these mature B-cell lymphoma, the monoclonal B-cell lymphocytosis, it has been divided into three this entities, that is low count MBL with CLL SLL phenotype, and then CLL SLL type MBL and non-CLL SLL type MBL. The B prolymphocytic leukemia is now excluded from the category of this small lymphocytic proliferations, and it is now included in the splenic B-cell lymphoma with prominent nuclei along with the hairy cell leukemia variant. Okay, the splenic B-cell lymphoma, the new entity is, like I said, splenic B-cell lymphoma leukemia with prominent nuclei, which includes cases of prolymphocytic leukemia which are CD5 negative. CD5 positive B prolymphocytic leukemia will go into the prolymphocytic proliferation of CLL SLL. Okay. And then splenic diffuse red pulp lymphoma, it has been further like better characterized morphologically and immunophenotypically to distinguish it from the other entities involved in the family of splenic B-cell lymphoma leukemia. Lymphoplasmacytic lymphoma leukemia, they have been further subdivided into based upon the IgM status. If IgM is positive, then in that case, and based upon the mid-88 mutation status, they have been classified as mid-88 positive or negative, mutated or non-mutated. And the non-IgM type is further subdivided into three, that is IgA or G, and then non-secretory LPL and IgM LPL without bone marrow involvement. Okay, so this is the new classification for the lymphoplasmacytic lymphoma. Marginal zone lymphomas, previously there were only two categories, nodal and extranodal. Now the extranodal is subdivided into two. One is extranodal marginal zone lymphoma and the other is primary cutaneous marginal zone lymphoma. This primary cutaneous marginal zone lymphoma, it was previously described under the extranodal part only now, but it is a separate entity because it has distinguished clinicopathological features. While this pediatric nodal marginal zone lymphoma, it was previously included in the nodal marginal zone lymphoma, but now it is separated as a distinct entity. Previously, it was a subtype of nodal marginal zone lymphoma. Now it is a separate entity. Okay. In case of follicular lymphoma, the grading is gone. Grading is not recommended because of certain regions. And the follicular lymphoma, it has been further subdivided into three entities, that is classical follicular lymphoma CFL, that is the follicular lymphoma that we classically used to call it follicular lymphoma, so that is classical. And the second one is follicular large B-cell lymphoma, which includes the cases which were previously classified as follicular lymphoma grade 3B. And the third category, which is new, that is uncommon follicular lymphoma with uncommon features. So it is further subdivided into two based upon the morphology, but as the name suggests, these follicular lymphoma, they have certain immunophenotypic and genotypic variations which are not common for the classical follicular lymphomas. Okay, so then the next and last entity for that we discussed today was mantle cell lymphoma. In mantle cell lymphoma, the entities remain the same, but the risk stratification has been improved. That is IGH CCND1 fusion that has been classically defined as a characteristic of this mantle cell lymphoma. And based upon the CCND1 rearrangement status, they have described a new part, that is cryptic rearrangement of this CCND1 along with involving the Ig, kappa and lambda genes. Okay? And in case of the cases which were negative for the CCND1 expression, in that case, they have described this new gene, that is CCNE for that. So that would be all for today. In the next time, I will be covering the large B-cell lymphoma and the Hodgkin's lymphoma and plasma cell myeloma, whatever the changes that are included in this. So for today, it would be all.